Hello, my name is Ila Sethi. I am a PET-CT fellow at Emory University, and I'm going to talk about brain death scintigraphy today. In my lecture, I'm going to talk about what are the indications for doing a brain death scintigraphy, how we do that, and how we interpret these studies. And finally, I'll talk about some of the quality control issues in brain death scintigraphy. What is brain death? As defined by various societies, and these societies have very stringent criteria for defining brain death. Brain death is defined as an irreversible loss of brain function, including brain stem. The prerequisites, as suggested by American Academy of Neurology, say that there has to be an evidence of catastrophic brain event compatible with brain death. Any metabolic abnormalities, including electrolyte or acid-base imbalances, have to be excluded. Any sort of poisoning, for example, barbiturates poisoning, has to be excluded, and the core temperature has to be more than 32 degrees Celsius to define brain death. The key physical exam findings in these patients are coma, apnea, and absent brainstem reflexes. The confirmatory tests, there are several that are available for brain death studies. There is conventional angiography, there is EEG, there is transcranial Doppler, and then there is technetium-99 labeled scintigraphy. What are the advantages of technetium-99 scintigraphy? It is easily available. We can do these studies by bedside. We have portable cameras available. There are no sedative influences, and there is no toxicity for these studies. What are the radiopharmaceuticals that are used for brain death study? For most part, these studies are a brain death scintigraphy is done with technetium-99 labeled tracers, and there are two types of tracers available. One that are brain specific, they cross the blood-brain barrier, and these include HMPO or Ceratec, or ECD or Neurolite. Neurolite is available but is not widely used, secondary to cost issues and availability issues. So at most centers, HMPO is used as the tracer of choice. Then there are non-specific agents that do not cross the blood-brain barrier, which is technetium-99 labeled DTPA, and this is rarely used if none of the other brain-specific agents are available. How do we acquire these images? So image acquisition in brain death study has two parts. One, the flow images, and second, the static images. Flow images are done at the time of tracer injection, and we do 1 second per frame for 60 seconds. And for when we are using technetium-99, the energy window is centered with 15 to 20% around 140 keV. And followed by flow images, we do static images in anterior, right and left lateral projections, if possible posterior projections. How do we do brain death study at Emory? So as I said, technetium-99 labeled HMPO is the most common agent that is used for brain death studies, and these studies we prefer to do them by the bedside because most of these patients are in the neuro ICU. Then we have a portable gamma camera that we use for these studies, and so this gamma camera is positioned for an anterior dynamic study of the head. The tracer is injected as a bolus, and then we acquire 2-second digital images for at least 1 minute. Followed by this initial flow images, there is a delay of 15 minutes, and 15 minutes after the injection, then we acquire planar images in the anterior and at least one lateral projection for a count of 200,000 counts per image. Again, the key to all these protocols is its initial flow imaging followed by static images, but different hospitals, they have slightly different protocols. As for example, at Midtown, we do 1 minute flow image followed by 5 minute statics. At St. Joe's, we follow the same protocol as here at Emory. At Johns Creek, we do 1 minute imaging followed by 10 minute statics. At Grady, we do 1 minute followed by 5 minute statics. And at Children's, we do 1 minute followed by delayed imaging at 25 to 30 minutes, which is slightly later than what we do in the adults. how do we interpret these studies? So I'm going to talk about how do we interpret the technetium 99 labeled technetium 99 HMPO studies first. So there is complete absence of intracranial blood flow as well as uptake. And then in literature you'll find mention of hot nose sign. What is hot nose sign? It is really blush of activity in the nasal region, which is noted in the anterior projection, and this is secondary to increased collateral flow from the external carotid arteries. So let's look at some images here. On the left here is a flow image, and as you see, this arrow points to the cranial region, and there is really no flow in the cranial region in comparison to elsewhere. And sometimes different systems, they use different color schemes. I have another color scheme here for you. These are also flow images, and as you can see, intracranially there is no flow. Then we have static images. I have anterior and a lateral projection, and as you can see, the arrow points towards no flow, uptake intracranially, and this is another color scheme that shows that there is no uptake of the tracer intracranially. This is the hot nose sign, as I mentioned. You can see that this arrow points towards a blush of activity in the nasal region, and this is because all the flow from the external this is because of the increased flow from the external circulation. Now let's look at a negative study. In comparison to the prior study, you can see that there is a tracer intracranially, and this is just a different color scheme showing a flow of tracer intracranially. Then we have some more static images in anterior and lateral projection that shows that there is uptake of tracer within the brain. Different color scheme, uptake of tracer in the brain. So once we have identified that there is absence of flow and uptake, how do we report these studies? So in our reports, we talk about what is the tracer used, what was the activity used, what imaging sequences were used to acquire the study, and then we talk about the flow and uptake to brain. If a study is positive, if there is no flow, if we don't see any flow or any uptake within the brain parenchyma, we would not say, instead of saying that there is brain death, we would say that there is no evidence of perfusion. And if you see flow, you would say brain perfusion is present. I have Emory template for you to look at. As I said, we would talk about in the technique section, we would talk about what tracer were used, what activity was given, how did we acquire the images, and if there are any prior studies. So the prior studies, sometimes we can do a repeat study if a study was initially inconclusive, then we can do a repeat study. And correlative imaging, sometimes there would be CTs or MRIs to look at, and it's pertinent to look at correlative imaging if available. So in the Emory template, we would say if there is no blood flow present, we would say that there is no blood flow above the circle of Willis, which is compatible with the clinical diagnosis of brain death, instead of saying that brain death is present. What can be the potential sources of error in a brain death study? Since we are dependent on the radio tracer, there has to be high radiochemical purity, and the pharmaceutical preparation has to be stable. Otherwise, there would be decreased availability of tracer, and we can get false positive results. Before injecting, we have to make sure that there is a working intravenous access. Infiltration of the dose or slow bolus can again impact the interpretation of especially the flow phase. Then there can be injection of the wrong radiopharmaceutical. I would just like to point out that the tracer that we use, Ceratec, It's blue in color because of the methylene blue that is present in most commercially available preparations. So it's just a tip to know. You can check with the technologist. If there is any suspicion, you can check with the technologist what color was the tracer, and if they say blue, you know that Ceratec was injected, the right radiopharmaceutical was injected. Sometimes they can be retained activity from a prior study using HMPO or ECD that can also affect interpretation. What is the role of SPECT in brain death imaging? As I mentioned earlier, most of the patients who get a brain death study, they are in neuro ICU, and they are dependent on life support systems. So it's difficult to bring these patients to the nuclear medicine area to do a study. So SPECT has a very limited role, and it's really reserved for selected few cases where interpretation by planar studies is difficult. And SPECT imaging is helpful because it allows better visualization of the posterior fossa. And so again, it's really reserved for very selected cases. In the beginning of my presentation, I talked about brain specific and non-specific agents. So technetium-99 DTPA is a non-specific agent that does not cross the blood-brain barrier. Hence, flow images are the key in the interpretation when we are using DTPA as the agent. And we have to look for presence or absence of intracranial activity in the flow images, and again, presence or absence of sagittal sinus activity in the sagittal images. Since this is a radiopharmaceutical that is rarely used, I am going to show you some examples from the literature. I do not have any cases using DTPA for a brain death study, so let's look at some examples from the literature. So in the flow study, there is intracranial flow present, as you can see here. However, in the uptake part, we don't see any uptake in the normal brain parenchyma. However, there would be uptake in the sagittal sinus. So for DTPA, you would only see intracranial tracer in the flow images, but no intracranial tracer in the uptake or later static images. What are the sources of error in DTPA scintigraphy? So as I said, we have to look for sagittal sinus activity. Sometimes some hardware that can mimic sagittal sinus activity. For example, if there is a tubing present, that can sometimes mimic sagittal sinus activity. Some patients with head trauma, they can have scalp hyperemia that can also mimic sagittal sinus activity here. To summarize what we just talked about, brain death scintigraphy is an easily available test. It's a confirmatory test. It can be done bedside. The tracer that is used most commonly is technetium-99 HMPO. And key to all the protocols at different hospitals is 1 minute flow followed by static imaging. And we have to look for presence or absence of intracranial blood flow and uptake. And finally, SPECT has limited utility in these studies, but it can be used in selected patients if there is any uncertainty about the diagnosis. Thank you.